I would take a really a two-pronged approach to this. And the first one is to get back to your pharmacist. You should have one pharmacist and one pharmacy that you can go to and really ask the questions and have them have a look at that. But in addition to that, you should probably make an appointment to follow up with your primary care physician.
Okay.
What I'm advocating here is a team approach so that you're getting two different perspectives, one from the drug side from a pharmacist, but also from the physician to actually look at the medical side for issues.
Okay. I mean, yeah. Um, and as I said, if I went there and grabbed his container, I could read off all the medications. You would know these medications.
Yeah.
But
I don't.
I think Sherry, maybe we'll have some time towards the end, and you
Yes.
can do that. And it's an opportunity to sort of look at the bigger issue, which you're bringing up, which is you see a change in the patient. They're dizzy, right?
Mm-hmm.
You see an actual symptom change, and you think, wow, could it have to do with? And I think the answer Adrian is giving is team approach, right? You must address it. The pharmacist is a key player. I don't think people realize, and maybe Adrian, you could speak more to that.
Well, I think that most people don't realize it, but actually, the kind of training we get for 3 to 4 years, equivalent for a physician is 1 year, if that, and it could be as little as 6 months worth of training in medications. So there is a difference in terms of understanding. Not that physicians are bad, because they do eventually gain quite a bit of expertise in their particular area. But the pharmacist's knowledge is much broader in terms of evaluating medications.
That makes sense. I mean, I know that I take stomach medication and just omeprazole, but if I get any other medications from the doctor, that's the first thing I ask the doctor: is there, or the pharmacist, is there any interactions I should worry about?
Right.
And then I ask about food or anything else I shouldn't mix with it, because I am so scared about having, an issue. So you're right. He's got a good pharmacist. He's got one who's supposed to. I haven't heard a call in a while, but they used to call like every other week and check in on things, and they haven't been doing it. So I don't know what that is. So.
Okay.
Wow. Yeah. So we've had a few more people join. We are recording. And as people share their personal stories and so on, we won't share this recording until we've asked each one of you if you're okay with this information being on a YouTube. Okay, does that make sense? Okay, good. Well, Adrian, let me just set you free. You've prepared something, and let's have it.
It's not so much a preparation, but I did jot down some notes about areas that I wanted to discuss today and share with you. And I encourage everybody to make this a very interactive kind of a discussion, because I think I'd like to hear from you what your individual problems are as caretakers, because this is a shared experience here. So I'm just going to start off and talk about the issues that caretakers actually see in the field, to see if we can add to this list. I was able to identify memory issues, visual issues, hearing issues, dexterity and manual issues, difficulty in swallowing, difficulty for you to help schedule the medications, and too many meds, as Sherry had just shared with us. Anything else I should add to that list that we can kind of go over today?
I want to ask you a question about what you just said, which is, are you talking about side effects that are possible when you gave us this list of visual, memory, swallowing? Or did I misinterpret what you meant by it?
No. In fact, I hadn't gotten there yet, because I'll do it now. There was a statement made by one of the researchers in a university that said that any side effect, any symptom that you see with a patient is potentially a side effect.
Mm.
And so, we should probably add that to the list of issues is any kind of symptoms at all. Because, anytime you see a symptom, we should be looking at potential for problems.
So that list then about memory, visual, and swallowing has to do with the patient being able to follow through as ordered.
Yeah, these are the
Okay.
issues that caretakers, and I'm taking their perspective now in terms of what they have to deal with.
Because a lot of the caretakers we're dealing with are actually handling the medication.
Right.
Yeah, so that in that case, that's a subset of caregivers. So,
Yeah.
and many of the people we're working with are in that category.
Yeah. But at the same time, one of the biggest values that caretakers have is the ability to observe. And not just to observe, but I would encourage all caretakers, if they feel that there's an issue or if they feel that something has changed, to reach out, to seek help and double check on the patient, really.
Yep.
Yeah.
Sherry?
Okay. Sherry, you have your hand up?
Yes. Well, another factor is like for me, I have stomach conditions that don't allow me to crush pills. So if somebody's beginning to have swallowing issues, then again, it's a case of finding out whether or not the medicine could be crushed, because some are not allowed to be crushed.
Correct.
And then, I mean, that's an important factor, because if it can be crushed, then you're in good shape. If it can't be crushed, then what's the next step? Do they have it in liquid form? So what is the potential of it being in a different form for somebody not to choke on it? Because my husband's beginning to have swallowing issues. So I worry about the same thing. What if what he has can I crush, and what can't I crush?
Yeah, and here again, your pharmacist is your best resource to identify what's crushable and what's not.
Okay.
So those are the issues that I wanted to bring up as kind of issues that caretakers generally see out there and have to deal with. As far as administration issues, Sherry talked about it earlier, where it's really difficult to schedule everything. You've got sometimes medications that have to be taken 3 times a day, and you have to figure out whether it's before meals, after meals. There are also certain medications where there's special kinds of requirements that a patient can't lie down for the first 30 minutes. So it becomes a very difficult challenge. I can tell you that within my career time, things have gotten better. We've gotten away from 4 times a day and 3 times a day to now mostly just once a day and twice a day. But even with that, we've still got scheduling problems with nighttime, daytime, before meals, after meals, with food, without food. So it's not an easy thing to do.
Can I ask a question about that?
Sure.
Sometimes the requirements for administering, like you say, can be onerous, and you can't really do it. What can you do? I mean, is it gray? Is it black and white? How do you work with complicated situations where, for example, the person can't wait a half hour before, eating in the morning, take the medication before, like you have to with, I think thyroid medication is very strict this way.
Yeah. The best thing to do is, here again, spend a little bit of time and talk to your pharmacist about what to do if you miss a dose.
Yeah.
That's a very important thing to do, because I know in the real world, everybody misses doses. I'm religious about my own medications, and yet occasionally I'll take it at night, and then about half an hour later, because I wasn't paying attention, have to really kind of think about, did I really take it?
I think that's for everybody.
Yeah.
Wow. Yeah. I'll just say I have a box, and I put it, and I couldn't do it otherwise. I have 1 med a day.
Yeah.
And I still can't keep track.
Yeah, so I've made it a point to really try to be focused when I do take it, but it's still a problem. And I can imagine for somebody who has less training, how difficult that might be. So there's ways to actually develop systems, and I can talk about that as well. I know through Daybreak, we're big advocates in terms of using the Medisets. But what happens when you have a patient that refuses to use the Medisate? They want to operate out of the bottles, and maybe it's a bottle that contains all the medications all in one bottle.
Mm.
Of course, we don't see that very often, do we? Well, it becomes a nightmare then, and obviously, there's some need for intervention with the family or the caregiver to actually know to separate the meds out of that one bottle into appropriate prescription bottles or Medisets. If they refuse a Mediset, the least you could do is keep it in the original containers because of the fact that, we have an expiration date and the fact that we have directions and we know what the medication is. And if that were to happen, I've seen systems where people have kept binders of administration, just like a hospital, where they will actually note down manually when the dose was being given. And a lot of hospital pharmacies, you might be able to actually get that same sheet that nursing uses, and basically they just do an X. They actually have the medication scheduled on the sheet for morning, lunchtime, dinner time, and evening if they need, and they can just check it off. It actually will show them what needs to be taken and when.
The piece of paper, the system?
Yeah, they have a system, and certainly any pharmacist can duplicate that, but that's what they do in hospitals. If they're not using barcode, the old-fashioned method was to actually use what they called a medication administration record. And it was basically a checkoff list to make sure that the meds were being given by the nursing staff.
And in lieu of that, they now have something that's online.
It's even more sophisticated. They barcode the patient's wristband.
Mm.
That I think that's beyond the realm of
Yeah, that's
individual.
why I'm talking about the old paper method. And, a system can be developed in the home setting to at least keep track of things to the extent possible.
Great. And it would be nice if we had something we could include in our newsletter, perhaps, about what a form like that might look like and where you would find it. So we'll try and do that for folks.
That's something we could also develop as a template for Daybreak as well. That's something I can do. How's that? So you can keep it on your files, and if we do have resistant patients that don't like Medisets, we can develop an alternative method, because I know I did see one consult just this past week or so where there was resistance.
Mm.
Great.
Would it be accurate to say, or feasible, that the caregiver could go to the pharmacist and do a run through of medications that are essential, that the missed medications when you fill them, when you give them past the missed date, would the pharmacist be the right resource and the available resource for that? I know people have a lot of trouble making appointments with their physicians because they're so busy. And I think sometimes, I don't know if this is true for Sherry, but it just seems to me if you had the resource of a pharmacist, you could get your questions answered pretty expediently. Is that
Very much so. I would encourage that, in fact, because
yeah.
very often it's not an extensive visit that's required. Maybe a simple question or two.
Some medications are absolutely imperative that you take it on time and you take it regularly and you don't skip a dose, and you replenish whenever you can after the missed timing.
Correct.
But, you know, sometimes if they won't take the whole, some people have a great pill burden. And if they miss a couple of supplements or recommended medications that aren't considered crucial, that might give the caregiver a little relaxation about any missed meds. Am I clear on that?
Very much so. I think that's a good suggestion. And speaking of pill burden, very often you can actually ask somebody to look at that to see if that can be reduced.
Yeah.
Very often I've made suggestions of changing a drug that was taken twice or 3 times a day to an extended release form, so it's only taken once a day.
See, and that's incredibly important.
And not that can happen in every case, but very often you can actually
Nice
reduce that list.
Yeah, nice when it can.
Yeah. So, Adrian, if the pharmacist if the pharmacist recommends a change like that, sustained release or something, does a patient or the pharmacist need to check in with a doctor about that?
Very much so. Yeah.
Okay.
Yeah,
So,
we need to check in.
okay, so the pharmacist would take that role then? They would,
Yes.
yes. Okay.
It could be either role. It depends on the patient too. I mean, they may feel more comfortable with the change with the physician, but certainly a pharmacist can make that phone call to the office as well.
And you would feel that was important? It's just a general question. Could the pharmacist change the medication in that way by themselves? Blah, blah, blah. You know what I'm saying?
In most cases, no. There are a few minor exceptions, but it would be good practice to actually communicate with the office so that everybody's clear in terms of what the current meds are.
Yeah.
Okay, so one additional area that often gets overlooked is proper storage of the medications. You know, the bathroom is traditionally a good place, but not. You know, it's a wet, humid environment normally, and really not a good place for medications. It should be someplace, elsewhere in the house that's going to be dry and of normal temperature. And also to think about what happens with medications that require refrigeration. A good example is insulin, where it's normally refrigerated, but yet can be kept at room temperature for 30 days. But if you do that, you better assure that the medication is discarded at the end of 30 days to make sure that the potency is still there.
Is that written on the medication, where the receptacle?
And no, because there's so many different forms of insulin today that you almost have to go case by case, because there are some that still require, for refrigeration, others that typically do not.
Are you confident that the patient or caregiver usually knows, been told? Is that information that they know it needs to be refrigerated, or it can only be out of the refrigerator for? Is that shared well? Do you know?
No, that is not shared well, because typically the recommendation is to keep it under a cooler storage. But accidents do happen. People get careless, and I hate to see patients actually waste the medication as well. So it's probably going to happen in an instance, and people are going to panic and to try to figure out what to do. Make that phone call to the pharmacy and ask. In fact, we do that routinely, where we'll get a question and we need to look it up. It's not something that's widely known by everybody, nor readily accessible. Sometimes we have to call the manufacturer.
Yeah. Yeah. Experts are not necessarily encyclopedias.
No.
They, they know when to find out and how to find out.
Yeah,
Yeah.
exactly.
Yeah.
Let's see what else have I have on my list here. Patients like to hoard medications,
Oh.
Mm.
and very often without expiration dates. So what do you do when you have what they think is good medication without expiration date? I would encourage you, throw it all out and start from scratch, and start to actually develop a system where you're using current medications only. Because, here again, just because it's sitting in a bottle, we don't really know how long it's been there. And uh, elderly patients very often like to hoard things. They don't like to throw it away because they don't like to waste money.
Yeah.
Very, very, very understandable, but at the same time, they're not considering the potential harm from safety and efficacy issues. So I would encourage everybody, to really do a good job in terms of keeping the prescription bottles and using the most current and cycling on a regular basis. And one of the best ways to actually simplify that problem is anybody here familiar with the medication synchronization? Big word here. Well, all that means is, let's say you have three different medications. One's a 30-day supply, one's a 90-day supply, another one 35. There are pharmacies out there that will actually synchronize so that they should be taken and completed on the same day, so that you can order all your refills once during the month or 90-day period. And it's also a very good method because now you're going to be able to see with fairly good accuracy, if it's done right, whether the medications are being taken correctly, because they should all finish at the same time.
Wow. How do they do that? I mean,
It's
well, they can,
a manual process. We actually have to go and figure it out. The first one's obviously the hardest, but the next one, if there's problems, you're going to start to see them pretty quick.
do you think most pharmacists can do this? You think Kaiser pharmacists can probably do this? I mean,
You'd
it
have to
sounds like it would
ask.
be
I
helpful.
think it's a little labor intensive for the pharmacies to do it, but there are actually pharmacies that specialize with this kind of a service.
Hmm.
So
Interesting.
something to explore to help medication adherence.
Hmm.
Just like the Medi set, you know whether it's taken or not, and it's just kind of an extension of that kind of same kind of a thought process.
Yeah.
Let's see what else here. I think it's really important that the caretakers understand what the medications are being taken, the reasons for it, and at the same time, with a lot of the elderly patients, to reiterate with them and continue to update them and remind them why they're taking certain medications. You don't have to really know a lot about the pharmacology or the science behind it, but just know that this medication is for your blood pressure, this is for your cholesterol, and possibly just even remind the patient as you're giving them this particular medication what it's for. Because elderly forget about why they're taking medications, and it's a good way to remind them about the importance of the medication as well. So just medication literacy, really, the more you can do there, the better off everybody is, whether you're a caretaker or a family member or a patient. I talked a little bit about the fact that any symptom could be an adverse event from a medication. And here are some things ones to think about. Is there a change in the drowsiness level of the patient? Are they confused or more confused? Are there any changes in their sleep habits? Are they urinating differently? Is there more or less from normal? Differences in appetite? Speech, has their speech patterns changed? Their Are they slurring? Are they talking faster? Are there kind of different kinds of memory issues that are cropping up? And not that any one of these different symptoms point to a medication problem, but it's a clue to actually check in with somebody to see if anything has changed, and yeah, whether it's a medical problem or whether it's a medication problem. And a lot of these problems can be subtle and they change slowly over time too. So it's good to reevaluate from time to time. An area I see also with the consults is over-the-counter medications and supplements and herbal products. Herbal problems can be a problem because there's so little information about interactions with drugs. So I would be really, really careful about herbals, and here again, a pharmacist is a good source of information for checking whether there is information about the herbals at all. Over-the-counter products, while they're generally safe, there are problems there. I recently just did one this week where a patient was taking Benadryl for sleep, which is a drug that actually is probably inappropriate for an elderly patient. And what I use for a reference for looking at drugs that are inappropriate for the elderly is a list called Beers criteria, and it comes from the American Geriatric Society. They actually will update this list from time to time, and they actually will make a statement in terms of which drugs they think are inappropriate for elderly adults. So it's a little bit complicated because it's more of a scientific reference for healthcare providers, but at the same time, it's a very comprehensive list and gives good reason why certain drugs might be inappropriate. And here again, this is only a reference for us to really guide us, because the one thing I've learned in healthcare all these years is you can't ever say ever, always, and you can't ever say never, because the truth lies somewhere in the middle. So it's really good just even though it's a never, to really evaluate and kind of think about it from a clinician standpoint, whether it's truly necessary or not. And so that's what makes our job sometimes interesting and challenging at the same time. Final thing that I wanted to talk about was I just mentioned Beers criteria as a good reference point to kind of look at, and not that you're going to be able to do much with it, but to get an idea of how much science goes into that particular list. Highly encourage you to use one pharmacy and find one good pharmacist, because if you find that one good pharmacist, stick with them, because they're going to be an incredible resource for you, and they're going to get to know you. When I was practicing a lot, I knew my patients. They would come in and I knew their meds just because I worked with them over a period of time. And then the
Can I
final.
ask you, Adrian, would you necessarily know if they had a new condition? Would that information also be part of your knowledge of them? You know what I mean? Because when you assess them, you know them, but something new could have happened. And how would you know that?
If they came into the pharmacy, it would be for a new med, right?
Yeah, yeah.
And I would know pretty quick.
Okay, yeah.
And a good pharmacist will also, if you have time in your practice, we engage the patients with conversation, and very often, we'll ask the general question of how are you, and we'll get a wealth of information if they're willing to talk. So I mean, these are more collegial kind of things, but at the same time, there are actual reasons why we ask those questions. It's more than just a casual conversation. It's a way to kind of dig a little deeper sometimes if they're willing to share.
Bedside manner for the pharmacist.
Very much so.
Counter side. Yeah.
The final thing that I wanted to talk about that's also really helpful is for a caretaker and the family member and the participant to actually maintain a current medication list. Because in an emergency, if the EMTs come in and you can give them that list and say, this is the current medication list, that's very helpful in emergencies. And, you know, it's an easy thing to do. And it's something that very often we overlook.
Mm.
These seem like important nuggets. Yeah. Can you speak just a little bit about what happens typically when people come home from the hospital? Because from my point of view, it can be a time when the medications are totally changed.
Yeah.
And you kind of clueless. It can't happen that you are clueless.
This is part of our dysfunctional healthcare system in the United States. And this is something that I even have to teach our students after 4 years of pharmacy training, is that they start off on the outpatient with a set of meds, you know, at home. They get hospitalized, and all those meds basically become discontinued, and another set gets started in the hospital because they don't want any complications. You know, they want to simplify down to the bare essentials.
Mm.
And then the patient gets well, and then they're given a set of discharge meds. And the discharge meds are only meant to bridge them over until they get reconnected with their regular physician. And very often those meds are different than what they came into the hospital with. And then the hope is that within a month period, they'll see their primary care physician, and there should be a reassessment at that time and a reconnection with the necessary meds as the primary care physician sees fit.
Whoa, that
So
sounds like a big deal.
it's a big deal. And in fact, there's a whole new area of pharmacy practice for that transitional period from discharge to home. And it's called transitions of care, because we know that there are problems that occur during that time period with reconnecting the patient and changes in meds. It's a very critical time.
Wow.
In fact, it's so critical for certain stroke and cardiovascular patients that Medicare actually has zeroed in on that as an area where there's a lot of readmissions because of problems. And that's how pharmacy started to evolve in transitions of care, because when we started to intercede in that process, we were reducing readmissions.
Yes, that comes down to money. Money speaks. But for the patient and their family, it really sounds like the pharmacist can be such a great advocate, a person to really help bring these complicated things together.
Very much so.
I'm impressed by that.
I don't have too much more to share. I think I've covered a lot of different areas to kind of pique your curiosities, and hopefully knowledge you can take and make practical within your settings. I'm more than happy to talk more about, other areas that you might have problems with, or individual problems that you're seeing with some of the patients you're caretaking. So I'll kind of open it up.
Great. Sherry, you have more questions. This would be a great time to get down and dirty.
My question is, have you seen that little, it's something you could get. I actually picked one up for Alan. I don't know how good they are. It's a little bag. And you literally could put it in the freezer and then put your insulin in it and take it with you. So you don't have to worry about carrying an ice chest. It's a tiny, it's a very tiny bag. And I was wondering how good those are, or am I better off to, if we are out going somewhere where it's real warm, do I have to still use an ice chest?
If it's warm, yeah, definitely. I mean, especially with the summer months coming, you don't need an ice chest, but those bags are quite wonderful. You know, it's not very specific. You just want to keep it cold enough without freezing it.
Okay. Okay.
Yeah, you could even use a Ziploc, but those bags are probably insulated, so they'll hold the coldness a little longer.
Okay.
What are they called?
I'm not real sure. Right now I have to actually go. It's too far away in the other room in the bathroom. It's just you'd find it. I think you find it where the containers. So the same area that you find in the pharmacy where you'd find the long containers to put your meds in, they're also at the same place.
Yeah, and it
Okay,
doesn't even have to specifically be for insulin, just something small, and blue ice would work just fine. I know
Okay.
during the pandemic, for the vaccines or flu vaccines, I would just have a lunch pail with blue ice in there.
Okay.
how many pharmacists are like yourself and have the time, energy, and are encouraged by their employers? And do you feel hopeful that people can really get time with their pharmacist?
If you get the right one, they'll make time. That's really what it boils down to. We're all stressed out there at the same time, but uh, a good practitioner who's truly engaged and enthusiastic would be willing to actually engage you after hours, after work. You know, it's as simple as maybe a phone call after hours to take care of a problem. And here again, if you establish that personal relationship with a pharmacist, they're going to be more apt to be able to do that kind of a service, because that's professional courtesy that I think many of us are willing to do in certain cases.
Mm.
It all starts with relationships, like anything else.
Very
Yeah.
much so, yeah. I just want to say that Adrian has worked with Daybreak with our medication safety program for many years. Your commitment to this process of helping people navigate the complicated world of medication is quite clear. And you're a great healer, you're a great healthcare provider. And I think it's worth shopping for that, level of support in your pharmacist.
Yeah, we're out there. You just have to find us.
Yeah.
Right.
Makes sense.
You know, if a pharmacy is too busy to talk to you and spend time when you really have pertinent questions, if they're not willing to give the time, it's time to find another pharmacy.
That makes sense.
Any more questions for Adrian, Dr. Wong? Well, we will be, this was recorded and we'll put it in our newsletter for folks. And Adrian's going to send me some highlights, and we'll make sure people have access to this information, written or through the YouTube with the link on the newsletter. So thank you all for attending.
Yeah,
And
thank you.
Thank you so much, Adrian, for your
Sure.
time.